Welcome back, everyone. In this recording, we're going to continue on our journey with pharmacokinetics, and we're going to start looking at the different mechanisms that allow drug molecules to be distributed. And then we're going to move on and describe factors and characteristics, that relate to the drug molecules that actually allow them to cross cell membranes. Now, in order for a drug to work, so to have its desired effect, whether that be on the heart muscle or an infected tissue or the brain or something else, that drug needs to achieve an adequate concentration in the target tissue. Makes sense, right? And this can be determined by drug translocation and chemical transformation. Now, I have said a couple of times before, about 80% of all of the drugs that we take is in oral form, so in a tablet form, and we swallow those and ingest them into the digestive tract. There is a disintegration phase or dissolution phase where, that tablet kind of dissolves and releases granules, and then those granules then release those smaller particles, being those drug molecules, right? So this drug then is dissolved in the fluids of the gastrointestinal tract. And then through the process of absorption, the drug then is absorbed from the small intestines into the bloodstream across the gastrointestinal tract wall. Now, this figure on the right is very useful to refer back to, and it does show you nicely the overlap between pharmacokinetics and pharmacodynamics. So we have a dose of a formulated drug, talked about disintegration of the dosage form and then dissolution and then absorption into the systemic circulation. Now, this is where I want you to kind of draw your mind away from this and think about, the trams in Melbourne or the trains, the underground in Sydney, or even just buses packed with passengers, right? And our passengers are going to be our drug molecules. And if you can imagine sort of, the inner city circle where passengers are hopping off after one stop, others going 4 stops, hopping off, others hopping on, and all of that. It's a little bit like this here, right? So the drug is in systemic circulation. Some amount of that initial dose gets eliminated straight away before it even has a chance to, interact with a target. So the drug is metabolized or excreted in urine. Some of the dose gets distributed, right? So distributed to organs and tissues in the site of action. Now, some of that then gets eliminated without interacting with the target either. Some amount of the dose, though, does have the pharmacological response, so interacts with the target site to produce that clinical response, right? Which is what we've taken the drug to begin to, to do. So that drug is displaying efficacy, part of the pharmacodynamics we talked about. The pharmacological response, though, can also produce adverse effects or toxicity. And so, you can imagine this happening until that, dose of that particular drug then is permanently removed from the body. Now, looking at physical processes that underlie drug distribution. Now, the concentration of a drug at any moment in any region of the body depends on these two processes, and they are bulk flow transfer and diffusion. In terms of bulk flow transfer, this is where drugs are being physically pushed, say, through the bloodstream due to the pressure gradient created when the heart contracts. And so this is how drug molecules are distributed over, wide sort of distances. It also occurs in lymphatic vessels and also in cerebrospinal fluid. So keep in mind that bulk flow transfer has nothing to do with the chemical nature of the drug. It's a physical process. Diffusion then is the movement of drug molecules, molecule by molecule, over very short distances. So down a concentration gradient from where they're high in concentration in one area to lower in another area. So say, for example, across the endothelium of a blood vessel. So now looking at movement across cell barriers, what you need to acknowledge is that the body is not a homogeneous environment, and there are many different types of cell membranes and compartments. So drug molecules need to be able to cross these cell membranes to be able to move from one compartment to another compartment. So this movement across cell barriers is required for absorption, distribution, and storage of drug molecules. Okay, giving you an example, let's say you take an ibuprofen, so a tablet, say a Nurofen tablet, and you swallow that Nurofen tablet and it's going to dissolve, in the fluid of the gastrointestinal tract. Those drug molecules then have to move across the gastrointestinal tract wall into the bloodstream. Once in the bloodstream, then they're sort of distributed to target tissue via that bulk flow transfer. And then those drug molecules need to be able to exit the bloodstream to actually enter the target tissues. Similarly, let's say you've taken a Voltaren that needs to be transported, to soft tissue to have an effect as well. And so just recognizing as well that there are different types of cell membranes in different regions of the body and in different organs depending on their function. For example, endothelial blood vessel walls tend to be quite permeable, whereas epithelial walls of cells lining the renal tubules in the kidneys tend to be more selective in what they allow to pass. Now looking at the factors that influence the movement across cell membranes or plasma membranes. We have firstly molecule size, then lipid solubility, and then ionization. Starting with the first one, which is molecule size, most drug molecules are small, so this doesn't tend to be an issue. However, if you think about a large sort of drug molecule, it is going to have much more difficulty crossing cell or plasma membranes, and it's also going to be less easily absorbed across the gastrointestinal tract wall into the bloodstream. So this is why if a large drug molecule needs to be used, it tends to be, injected directly into the bloodstream or directly into the affected tissue. The next factor is really important, and it's lipid solubility. So if you think about a non-polar molecule, it doesn't have a charge. Therefore, it's going to be lipid soluble, and it moves across membranes way more rapidly than polar molecules which have a charged molecule which are water soluble. So if you think about a non-polar molecule, it's going to be miscible in the predominantly, hydrophobic phospholipid bilayer, and therefore it's going to pass through more rapidly than a polar charged water-soluble molecule. Now that does bring me to ionization. And ionization, if you remember, describes how an atom or a molecule gains a charge by either losing or gaining an electron, and this often happens in aqueous solution. So if we bring this forward to drug molecules, we've talked about unionized molecules don't have a charge, therefore they are lipid soluble and they can cross the predominantly, hydrophobic phospholipid bilayer of the plasma membrane. Ionized drugs, though, have a charge. And once they gain that charge, they are polar and they are not lipid soluble, they are water soluble. So they're going to really struggle to try to cross that predominantly hydrophobic phospholipid bilayer. So ionized drugs, to be able to cross, can use transport systems, and that's what we're going to talk about now. Basically, there are four main ways that small molecules cross membranes: either direct diffusion, facilitated diffusion, or combining with a solute carrier molecule, or via penocytosis. So if we just go back here to direct diffusion through lipid membranes, this can only happen with a non-polar substance, so a non-charged, non-ionized substance, so only lipids. So if you think about steroids, for example, they can freely cross through the phospholipid bilayer via direct diffusion. We have facilitated diffusion through aqueous pores or channels. For example, ion channels, right? We also have these aquaporins here that are used for, water and urea. However, these aquapores and channels are usually too small for drugs to pass through. So remember, facilitated diffusion is still passive, but it is diffusion that needs to be facilitated. So through the use of a channel or a pore. The third one is combining with a solute carrier molecule, for example, amino acids, and this is shown very clearly here, where you have an amino acid binding to one side of the carrier protein there on the extracellular side, and then being transported into the cell and being released on the intracellular side there. And finally, we have penocytosis. And penocytosis, remember, refers to kind of drinking of molecules. So with penocytosis, there is an infolding of the cell membrane, which you can see here, so that a pucker or a balloon or a vesicle kind of forms around the drug molecules. And some of the larger drug molecules cross membranes in this way. So you can see here via penocytosis, we see this vesicle being formed. We're inside a blood vessel here, everybody, and then being exocytosed there across that, the endothelial cells there lining that capillary. And this is the way insulin leaves the bloodstream then to interact with its target tissue, say, for example, skeletal muscle. Now looking at carrier-mediated transport a little bit more closely, and many cells' membranes possess specialized transporting mechanisms. So these aqueous parts of the plasma membrane that facilitate the transport of water-soluble substances. So they regulate the transport of sugars, amino acids, neurotransmitters, and metal ions, either by facilitated diffusion or active transport. Facilitated diffusion, as I've mentioned before, is passive. It is using channels, pores, or transporters, and that's where the facilitated bit comes in, to move substances down their electrochemical diffusion gradient. So from an area of high concentration to an area of low concentration, with the use of one of these channels, pores, or transporters. Active transport, on the other hand, it describes the movement of substances against their electrochemical diffusion gradient. And of course, this is going to require energy, right? So the transporters then use energy from the breakdown of ATP to pump molecules against this diffusion gradient. So to pump molecules from an area where they're low in concentration to an area where they're high in concentration. Now, the number of available pumps, channels, pores, or transporters can limit the movement of specific substances. And saturation kinetics describes the transport of a substance relative to the number of available pumps, channels, pores, or transporters. When there are an equal number or more pumps available compared to the particular substance that needs to be transported, all of that substance will get transported. However, if the level of substance exceeds the number of available transporters, then some of that substance will not be transported because there's literally insufficient number of pumps to do it, okay? And we talked about this kind of before in physiology, where we introduced glycosuria, which we see in uncontrolled diabetes. Now, glycosuria just describes the presence of glucose in the urine. So there shouldn't really be any glucose in your urine. But under normal conditions, if somebody does not have diabetes and they have normal level of blood glucose, remember all glucose in the bloodstream gets filtered into the renal tubules. And by the end of the first windy bit of those renal tubules, so the proximal convoluted tubule, all of that glucose should be reabsorbed from that filtrate via a sodium glucose co-transporter, right? But what we see in uncontrolled diabetes is not normal blood glucose concentrations. We see abnormally high blood glucose concentrations. So all that glucose gets filtered into the renal tubules and it's flowing in the filtrate past that first proximal convoluted tubule. So the number of pumps don't change, so they reabsorb, or transporters in this case, they reabsorb as much glucose as they can, but because we have this chronically high level of glucose, some of that glucose gets left behind in the filtrate and it enters parts of the renal tubules where there are no glucose transporters. And then this is why it enters the urine then and permanently excreted from the body, and then that is then diagnosed as uncontrolled diabetes through testing of that glucose in the urine. The second one then is competitive inhibition, and this describes the effect of when a second ligand binds to the same carrier. So here we've got two different sort of ligands or substances, and they're competing for transport here via this carrier protein, right? So obviously, if one of these binds preferentially to the carrier protein, it is going to be transported preferentially over the other one. And that's then going to limit the transport of that one. So watch out for that one when you're doing your research for your presentation as well. And where we find this really important is in the renal tubule. In our case, if we're talking about drug molecules, a lot of the drug molecules are too big to be filtered. So they need to be secreted into the filtrate to be removed from the body. And we often find that there are two drug molecules that, require the same transporter to be secreted into the filtrate. And in that case, one wins over the other and follows its normal pharmacokinetics, whereas the other one doesn't, and it's left in the body for longer and has a prolonged effect, and that might involve adverse effects. We also see it in the biliary tract, also in the blood-brain barrier, and the gastrointestinal tract. So that's important at the level of absorption, and of course the placenta as well. And that obviously then affects the transport of drug molecules here and between the mother and the developing fetus. So we're just going to finish up here by looking at diffusion through the phospholipid bilayer. Don't get too bogged down about the terminology here. We're not going to ask you to calculate anything with this. But diffusion is determined by the diffusion gradient. So how steep the diffusion gradient is between 0.1 and 0.2. The steeper the gradient, the greater the rate of diffusion, right? The physiochemical properties of the drug. So for efficient translocation across a plasma membrane, drugs must mix well with lipid and move easily within the bilayer. Lipid solubility, therefore, is an important determinant of drug pharmacokinetics, and it's expressed as the partition coefficient. What does that mean? It means the ratio of drug in the lipid phase versus the aqueous phase. And diffusivity then, which is a measure of the mobility of molecules within the lipid, is expressed as the diffusion coefficient. So diffusivity doesn't tend to vary much between different drugs. So it's the lipid solubility then that largely determines the rate of drug absorption from the gut, penetration into the brain, and the rate of renal elimination. Now, if you think of this penetration into the brain, it's really important. I'll give you an example. For people in the late 80s, early 90s, the first antiretroviral therapy drugs that were rolled out to treat HIV positive people and people with AIDS had some success, right? But because they couldn't penetrate into the brain, so they couldn't cross the blood-brain barrier, a specific condition known as AIDS dementia complex, which was a progressive dementia that affected about 30% of HIV positive people, wasn't able to be treated, okay? But thankfully, as time went on, they did find drugs that could cross the blood-brain barrier. And this AIDS dementia complex, which is what I did my doctorate on, is no longer a thing. The whole terminology has changed. There is, a dementia still associated with HIV in some people, but because it's much sort of milder than AIDS dementia complex, it's now called HIV associated dementia. Now, the permeability coefficient is a measure of how well drugs diffuse through the lipid bilayer, and it is the number of molecules crossing a certain area of membrane in a given time. And the physiochemical factors contributing to the permeability coefficient are the lipid solubility and the diffusivity itself. So this lipid solubility is really important in determining how well drugs, diffuse through the lipid bilayer.